So we have been managing infectious diseases of pandemic nature from smallpox to the latest COVID-19. So our institution has the expertise in COVID-19 from the very first patient up to now. So we have cared for nearly 7,000 plus COVID-19 patients, including the very critical patients, which will amount to something like 400. So the experience that we gather and the experience that we are going to share with you today may not be available in textbooks or journals or any other guideline to that matter, because we learned COVID clinical management in the hardest way. So because when there was no knowledge was available. So it is a wonderful opportunity, I presume, for you to sort of make use of this opportunity as much as possible, because with the clinicians that will be presenting today and tomorrow are simply the best of the nation to talk about these topics and to sort of make aware you of the concerned areas, because they have had experience from the very first patients up to now. So I hope that you will make opportunities, make this an opportunity to expand your knowledge and experience towards it. And also, I would like to invite you to listen to them carefully, and the attitude that carries along with their presentation, the passion for patient care is the most important thing. So what we find recently in our health setups is that that people think that this is kind of a disease that it was quite unfortunate that a lot of people got infected and a lot of people died. But other than that, I must emphasize that if we uh, work as a team, we can save a lot of lives. We can, in fact, there is a capacity development required in an institution to facilitate COVID, and most of all, the team spirit and the team capacity should be built. So for that, you can give a leadership as young doctors when you come into uh, when you embark on the medical profession with the other categories such as nurses, minor staff members, the paramedics, and professional supplementary medicine, because the house officer's role is more or less a coordinating job. So this is very important, and we will be covering the clinical care, the history and examination, including the history and examinations and investigation, and drug management, attending to emergencies, and also the microbiological inputs such as tips to survival in medical practice, the infection control, and the dead body management, which is very important. So that would be an area that you may encounter a lot of medical legal aspects. So you can ask questions from our presenters in the chat box, and if they have time, they will of course answer. And today, at the end of the day, there is a case discussion. So mostly these clinical scenarios are being made, prepared objectively and intentionally to sort of reinforce your knowledge gathered towards the morning session. So listen to these lectures very carefully so that you will be in a better position to come up with answers in the case discussion. So one of our very senior consultants will be attending to that, and Dr. Damayanti Dampitiya. And if I am to introduce our presenters today, Dr. Ananda Vijay Vikram, I don't think that you need any kind of introduction. He's a kind of a nationally regarded consultant and a very experienced consultant. He's our lead clinician in the National Institute of Infectious Diseases. He would be doing the topic spotting the bad patient in a group of good patients in the clinical management of COVID-19, which is a very interesting topic. And then we have a presentation by one of our consultant physicians, Dr. Situmini Pahalagamage, investigating and treating a COVID positive patient. And we have another approach to management of COVID patient. Dr. A.G.S. Asri, one of our consultant physicians, will be presenting, and mostly this would incorporate emergencies also, not only the drug management but certain emergencies also. And our radiologist, Dr. Kishan Yabevardhana, will be giving you some imaging inputs to diagnose COVID-19 in Sri Lanka. And Dr. Channa Pereira, as I've told you, is our consultant JMO. He will be dealing with the medical legal aspects in the clinical management of COVID-19 and important know-how in the management of COVID dead bodies, right? So you may have learned a lot about how to manage to the clinical managements until the patient dies, but after the patient dies, what you have to do, this is also important to know. And the next day, after lunch, we will invite you for the case discussion, and where Dr. Damayanti Dampiti, one of our senior consultants, will be attending to that time slot. And the next day, we have a presentation, infection control in day-to-day clinical practice. This is once again very important because in this pandemic, we observe a lot of our healthcare workers, including doctors, fall sick due to COVID, and we lose their, some of them have lost their lives, but we actually really don't know whether it was community acquired or they acquired through the hospital. Whatever said and done, it is very important that you adhere to do. There is a general perception that doctors pay other categories who pay least attention in infection control, especially with regard to personal protective equipment and universal precautions to that matter. So that is not recommended in this plight of the pandemic, because if the health worker becomes ill, then preventing this pandemic and strategies to control the infection control will be simply out of the question. So it is very important that you get these tips for survival in day-to-day clinical practice. That's more or less the infection control in the COVID outbreak. And the proper use of personal protective equipment. This is a practical session. Will be done by our senior matron, Mrs. Geeta Udugama Korala. Again, a very interesting session because she has been the national resource person for so many months by far to teach a lot of people in our health community on proper use of personal protective equipment. It is one of the very important aspects in infection control within our health team. So there are sort of, if you have inquiries, you can ask her then and there, then she can clarify. So these are the topics that we'll be covering in this training session. So I hope that you will make the maximum benefit out of this session, a session that you cannot miss, and a session if you miss, there is no way that you can get that experience again from another session. So it is so important, and we welcome you to this medical profession, and we hope that we will thrive up to become good doctors for this nation and to help us control this deadly outbreak COVID-19 in Sri Lanka. So may the glories in what you do never fail. Thank you and thanks a lot.
I think the next one will be Anand sir. Sir, I hope you are here. I think you have made the co-host by Dr. Roshan. So you can start your presentation. I guess Asita said you of course need no introduction.
Yes.
Thank you again for coming and thank you again as always coming and trying to develop the competencies of these young budding doctors in coming to, who will be starting their internship most probably in next month. Over to you, sir.
Thank you, Dilanta. Yeah. Today, mainly I'm going to talk about some overview of patient care in COVID, and especially how to differentiate good patients and bad patients, and the importance of that. If you see the situation, how it was in early part of this year, the world situation was like this. This was how the case numbers are going up, and this was how the number of deaths are going up. So we had daily deaths of about 16,000 worldwide, and the case numbers are going around 750,000 per day. And the situation as of today is grave. Up to now, as of yesterday, worldwide it had been reported as 223,000 cases, 223 million cases, sorry, and 4 million plus deaths. And you can see the waves of this coming up. This may be the continuation of the first wave, or maybe some people call it, or depending on the country, you may call it the second wave, and another wave, and now another wave. In some countries, this is called the third wave. In some, it is called the fourth wave. Whatever it is, you see these waves of this outbreak coming up. And this has led to many number of deaths. And this was understood as early as middle or end of last year. This was an editorial published in JAMA, one of the, as you know, one of the most reputed journals, medical journals, where they were referring to excess number of deaths in the US and in other countries. And you can see some of the news items regarding the increasing death toll in various countries. So as we know, in many countries, thousands are getting infected, thousands are getting infected, and thousands are dying, and thousands are dying, and hospitals are overflowing. And in some countries, necessary protective equipments were running out of stock, and doctors, nurses, and other health staff is getting infected. This was a news item a couple of months ago from India about deaths of doctors. In that outbreak, by that time, that was by mid-May, about 400 plus doctors died. But that was only in the second wave. In the first wave, many more died. So, which means, all this means that we have to face and live with COVID-19. It is unlikely that this is going to go away from us within the next few months. It's very, very unlikely. And it is quite possible that this is going to remain with us for at least another year or so, if not more. We know there are occasions where outbreaks, when these sort of epidemics come, they have gone on for 2-3 years. Occasionally, things settled within a shorter period. But when we had severe outbreaks like this, they have gone for 2-3 years, like in the influenza outbreak in 1919, and then several other influenza outbreaks have occurred. So this high number of cases and high number of deaths have posed a threat to us. This is an article published in the Lancet, the BBC, more than a year ago, at the beginning of at the early part of this epidemic. Still, what is said in this article are true and valid. That's why I thought of showing some of these, highlighting some of these things mentioned by this author. So it says, rarely has the threat of disease occupied so much of our thinking. For weeks, almost every newspaper has stories about coronavirus pandemic on its front page. Radio and TV programs have back-to-back coverage on the latest death tolls. And depending on who you follow, social media platforms are filled with frightening statistics, practical advices, or gallows of humor. So even now, this is true. In spite of the outbreak has gone for more than a year since this article had been published. And this constant bombardment, the author continues to write, saying this constant bombardment can result in heightened anxiety with immediate effects on our mental health. But the constant feeling of threat may have other more insidious effects on our psychology. Due to some deeply evolved responses to disease, fears of contagion led us to become more conformist and tribalistic and less accepting of eccentricity. Our moral judgments become harsher and our social attitudes more conservative. I believe all these are true as of today as well. So what are the effects of this? We see discrimination of patients by the society and healthcare facilities, and sometimes we see criminalization of COVID-positive people in the society again. And this has led to closing down of factories, offices, movement restrictions, and economic recession. And then there are other effects like more use of internet, etc. And we know even the medical faculties were closed for many, many months. And in fact, I was arguing and wondering why the faculties were closed. Because I thought this was the best opportunity for a medical student to learn how to protect themselves from infections like this. This was the best opportunity for a medical student or future doctor to learn how to practice infection preventive measures. And most of you all lost that opportunity, unfortunately, because of the fear. Because of the fear of maybe in your mind, maybe in the minds of your lecturers and professors, or maybe in the minds of your parents. Of course, there are other factors too, because people were living in boarding houses and hostels, where it can be difficult to practice some of these precaution methods. But however, as I said at the beginning, we have to live with this infection now. So what should we do in hospitals? Since you will be working in hospitals you will be starting to work working in hospitals within next couple of weeks, it is important to know this. The first priority is the safety of healthcare workers. Now, this is an unusual situation because in the hospital, we always say the first priority is the patient. But in this pandemic, this has changed for valid reasons. The priority number one is the safety of healthcare workers. Otherwise, it will lead to refusal to see suspected patients, refusal to attend patients until a negative PCR is available, unnecessary use of personal protective equipment, and then employing measures to distance patients from healthcare workers, like partitioning of wards, using robotic trolleys to distribute food, etc., and producing equipment for distant care, and so on, which are useless, especially in the context of this pandemic. But unfortunately, we have seen this from happening because of the fear. So how can we overcome the fear? Once again, the most important, this is a Lancet article published last September, again highlighting the safety, the importance of the safety of healthcare workers. It says no patient safety without healthcare worker safety. So first, the healthcare worker has to be safe, and then only we can ensure the patient safety. So how are we going to ensure the safety of ourselves? Mostly these are simple measures. Hand washing, practicing cough etiquettes, avoiding unnecessary gatherings, maintaining physical distancing, minimizing touching surfaces unnecessarily, disinfecting surfaces, face masks wearing properly, and use of personal protective equipment appropriately and correctly. Now, if you come to think of this, I'm sure as medical students, many of you all have adhering to these practices, sometimes accurately, sometimes not that accurately. But the important thing is that this, I am sure this will be highlighted by the microbiologist tomorrow in her talk. If you look at the infections of healthcare workers, now if you take our hospitals, till last December, we did not see any infection among the healthcare workers in our hospital because we were adhering to these precautions. When in last December, you know, if you remember, we had a community outbreak, and with that, people started acquiring the infection. So they did not acquire, the healthcare workers, the doctors and nurses, did not acquire the infection from patients. Because when they were attending to patients, they were taking necessary precautions. However, they acquired it from the community. And when a person working in the hospital acquired it from the community, that person sometimes tend to spread it within the hospital. Because we were not adhering to some of these practices, especially when people were having tea or meals, especially lunch or dinner, people were together, talking to each other, sometimes sharing meals, and then we forget these necessary essential practices. And with that, there had been infection of other people. So that's what happened, that's what led to infections in our hospitals mostly. So once again, it highlights the importance of adhering to these precautions at all times. Not only when we see patients, but when we are together as healthcare workers, doctors, nurses, or in the ward staff, we have to adhere to these precautions. So here you see one of our nurses with all the personal protective equipments, and on the right hand picture you see a nurse is taking blood from this patient. So wearing all this PPE, we adhere to, we do the necessary things for patients. Well, the purpose of having these personal protective equipments is, one is to safeguard ourselves, and the second is to attend to the patient. These are seen from our ICU. You can see the people are wearing all the personal protective equipments, and they were attending to a patient. So once the priority one is ensured, the safety of healthcare workers is ensured, we have to ensure the other priorities take place. So we have to give appropriate care and treatment to COVID negative patients as well as COVID positive patients. And that is the purpose of ensuring the safety of ourselves. So once that is ensured, we have to make sure that proper care to the patient is given, whether they are COVID positive or not. So here you can see this is one of our COVID patients who had a big pleural aspiration due to some other pleural effusion due to some other reason, and this is me aspirating the pleural effusion. You can see the bottle is filling with serous fluid. She had a large effusion. So while taking necessary precautions, we attend to these patients. And then when the encounters are not so close, we don't need to have all these personal protective equipments. Now here you can see this one of COVID patient, this one of our nurses handing over a packet of rice to this patient. The patient is wearing a mask, the nurse is wearing a mask, and there's a distance of more than 1 meter, and so this protection is adequate. This protection is adequate because this infection is not airborne. When we go close to the patients, having close encounters with the patient, we have to make sure that we wear full PPE, but at other times, those are not necessary, and we can attend to these other things with general measures, general personal protective measures. Here you can see we were talking to some of the COVID positive patients. These are some of the Navy personnel admitted to our hospital, most of them with mild symptoms. We got some donations for them and we were about to distribute those to these patients. And you can see these are our wards. We have half-wall wards with good ventilation, good light, and you can see we were wearing face masks and patients are wearing face masks. There was more than adequate distance between the patients and us. And if you want to double sure that you are safe, you can put a big fan like this behind you so that the airflow is directed away from you. So even the slightest risk is minimized or abolished when you do things like this. And in this sort of environments, the risk of having infections is minimal. These are open environments with good ventilation. We'll come to that again later. It is very unfortunate to see that in some of the hospitals, these wards were partitioned and the ventilation was reduced or almost put to zero, right? And that increases the possibility of these infections. We did not do any structural changes to, you can see, we have not done any structural changes to these wards. So what we did was, when we go into the ward, we wear full PPE, otherwise the patients are in these wards. And not only that, we try to attend to their other needs also. This was the birthday of this girl. So this is a nurse whom the nurses made some cavili and took to the ward. And so we try to look at those aspects also. And also, these patients are not, this was early part of or middle of last year, where patients were not, most of the patients were mildly symptomatic or asymptomatic, and we allowed them to come out of the wards to get some fresh air and do a little bit of mild exercises. So once again, the key methods of prevention are the hand washing, practicing cough etiquette, social distancing, minimizing touching surfaces unnecessarily, good ventilation, good sunlight, and for people it is important to avoid smoking, and it is important to wear face masks properly. And often you see this is not practiced, the wearing face masks properly. People have a face mask on their face, maybe on the chin, maybe on the neck, but sometimes it's not worn properly. This study done in Japan, or article published from Japan, following certain studies, some studies, which showed in an indoor environment, enclosed environment, the risk of transmission is 18 times higher compared to outdoor environments. So the article goes on to say, especially when combined with environmental factors such as poor ventilation and crowding, enclosed settings may lead to further increase in attack rates. So the largest outbreaks have occurred from long-term care facilities and also workplaces, including factories, where many people spend several hours working together, dining and sharing communal spaces. So this is the problem. And therefore, once again, we have to stress the need of good ventilation, especially in the hospital settings. So if you're having meetings, have it outdoors, or even if it is indoors, make sure that the windows are open, you have good ventilation, put the pedestal fans or standing fans rather than ceiling fans, shut off air conditioning. So the article continues, finally, because crowded indoor spaces and gatherings likely will continue to be the drive of transmission, public health strategies will be needed to mitigate transmission in this setting. As part of the pandemic response, we may need to consider fundamentally redesigning these settings, including improved ventilation, just as improved sanitation was a response to cholera. As we know, the cholera is almost eliminated from the world because of improved sanitation. It's still there in some countries where sanitation is poor. So when you come back to the ward, you get a lot of patients getting admitted. Some of these patients may be having COVID, and these days a lot of these patients are having COVID. And some of these patients may be bad. Either it can be both COVID patients or non-COVID patients. And these patients, the bad patients, need early attention, because delay in treating these bad patients can make things more complicated, and they can lose their lives even. Finding the bad patient is the challenge, especially in the setting of this COVID. Okay, I'll address this question now itself. So the question, there's a question in the chat box asking, enlighten what you mean by COVID is not airborne. Does it mean it does not stay in the air for a long time and transmitted only when there is an infected patient? Now, if you remember your botany learned for A levels, you remember that we learned about the propagation of plants. Some plants are taken to, the seeds are taken to various places by birds. Some plants, the seeds are taken to other places by the wind. And those are that is the airborne, what is called airborne. Or it is transmitted by air. So from one place, it can go to another place by air. So that is the actual meaning of airborne. So why I said the COVID is not airborne is, if your next door people are having COVID, if they keep their windows open, you keep their windows open, you are not going to get COVID from them, because it's not airborne. In contrast, if you think of a condition like tuberculosis, that is different. So what happens in COVID is, as we know, it's a droplet infection. The droplets go out of the body with coughing, sneezing, talking, and these droplets travel for a distance of about 3 to 4 feet, and then they drop to a nearby surface, either to the floor or to a table or to a chair. It does not go to a place meters away from the patient through the air. That is why it is not airborne. However, it can be suspended in the air for a certain period. And this period of suspension is more if it is an enclosed space, and if it is an air-conditioned space, the period of suspension is more. So if it is a good, well-ventilated place, the period of suspension is less. That is why the transmission is less in a well-ventilated place. If it comes to an enclosed air-conditioned place, the period of suspension is more. So if a patient goes into an enclosed air-conditioned space, cough or sneeze, come out of that place, and you go into that place, the patient is not there, but the suspended droplets are there. So if you are not wearing a mask in that space, face mask in that space, you can get the infection. So that is why we have to make sure that we are wearing the mask properly at each and every place, except at your home. So that is why it is not, that's why I said it is not airborne, but it can suspend in the air for a certain period, longer period in an enclosed air-conditioned space, and you have to make sure that you wear a mask properly. For that, what we use as surgical mask is enough. If you wear it properly, covering your nose and the mouth, that is adequate. If you're having closer encounters with the patient, spending more time within the patient, say if you are taking blood or blood culture or doing other things, putting catheters, various things to a patient, the surgical mask is not enough. Then you have to wear N95 mask or an equivalent. There are the equivalents like KN95, that sort of mask. So that's the difference. Okay, so we'll come back to about the bad patients. So it is important to find the bad patient because that helps to prioritize our work. And then also we have to decide who should be treated first, because delay of treating a bad patient can be costly. Early detection and treatment of a bad patient will save lives, time, and resources. So some places use a triaging system for this. And such triaging system is based on various things like history, observation, examination findings, investigation findings, and other factors like comorbidities. So you can consider many of these, and some hospitals have different schemes for triaging. So, okay, what is necessary is to have a good system for triaging. So history is very important in triaging. If the patient is in this COVID era, if the patient is having respiratory symptoms, this period of the day, this period of the time, you have to think of COVID. If the patient comes with sore throat, cough, sneezing, rhinorrhea, body aches, the common symptoms of COVID, because COVID is so common in the country, so that should be the first differential diagnosis. The important thing is, it is important to ask how the patient is feeling. Patient might say that patient is okay. Contact with COVID patient, of course, this is not valid now any longer because it's everywhere now. COVID is everywhere, so you don't have to ask for a contact with the patient. But if there are a diagnosed patient in the household, that almost make certain that your patient has got COVID. Medication history, and the one important thing you have to understand is when the patient is at rest, patient may feel comfortable. Patient may tell you that I am all right. Mata prashnayak naha, amaruwan naha. Those things can be told by or felt by the patient when they are at rest. I still remember seeing a patient just 2 weeks ago. This patient, when I went to see the patient, when I got the details before seeing the patient, I knew the patient was on 15 liters of oxygen. When I went to see the patient was having her meals. She had removed the mask. She was eating something. So I asked how she is. She said she's better. She feels better. I checked the saturation using the pulse oximeter. Her saturation was 70%. So the message is, even with quite low saturation, if the patient is at one place without exerting, patient might say the patient feels all right. Therefore, it is very important to ask the feeling of breathlessness with mild exertion, like going to the toilet, talking over the phone for a couple of minutes, getting up from the bed. This sort of even mild exertion will make the patient hypoxic. And again, if the patient is on the bed, patient might not complain. But if you check the saturation, even turning in the bed can put the saturation low. Saturation going down. Patient who is having saturation of 90 can have a saturation of 85 when the patient turns to a side. That is because even that slightest exertion can make the patient hypoxic. And then you have to ask about vomiting, nausea, and I forgot to mention loose motion here. In some of the COVID patients, loose motion is a common and important symptom. So the reduced urine output, you have to ask these things. And the loose motion becomes more important because if it is frequent, they will have to, in a patient who is on oxygen, they will have to go to the toilet often, and that will make them hypoxic. This observation is very important. I'm sure most of you have read Sherlock Holmes, and the Sherlock Holmes, in one place I still remember reading this close, and it stuck in my mind. The Sherlock Holmes told Dr. Watson, Doctor, you see, but you don't observe. So we see a lot of things, but we don't observe. But when it comes to a patient, that is necessary. As Sherlock Holmes was doing, we don't have to observe the number of stairs in a staircase. But when it comes to a patient, it is necessary. It is our job. If you don't observe things in the patient, things can go wrong. Respiratory rate is one of the most important things in COVID patients. And some of these patients, the respiratory rate may be difficult to count or assess by looking at the chest, because their breathing is often abdominal. You have to look at the movements of the abdominal wall to assess the respiratory rate. Heart rate is again important, oxygen saturation, and whether the patient is sleepy or confused, that can be due to hypoxia or increased carbon dioxide in the blood. So these are very important and essential observations we have to do daily or more frequently in these COVID patients, because these are the most important parameters when it comes to COVID patients, which will show which way the patient is going. And if the patient is hypoxic, it is important to detect that early so that we can treat that early. If the hypoxia continues for a longer period, the patient can have complications and even die. So the measuring pulse oximetry is important. As you know, there are many pulse oximeters. These the digital ones, and these are also portable ones. Of course, the multi-parameters are better, but I prefer this one because it's not that expensive. You can carry it. It's easy to carry rather than carrying a multi-parameter, and also you can put it on a desktop or even on the bedside table, and this reliable too, rather than a digital one. So in the ward, always try to use this rather than this. And if you have the multi-parameter, that's okay, but always make sure that these well calibrated, properly calibrated, because sometimes if these are not calibrated well, they can give false readings. So observing the patient is very important, as I said. Now for this, you need physical observation. You can't observe this patient with the CCTV. You can't get an idea about the respiratory rate of a patient by looking at a CCTV, using a CCTV to monitor a patient. So don't use CCTVs for monitoring of this patient. That is absolute rubbish. If you have any CCTV in the ward, never look at those unless you can use to see whether patient is going out of the ward, so that sort of things, but not for the monitoring purposes. And of course, it is not essential to go into the ward all the time. You can ask a good patient to help. The patient might help you to put a pulse oximeter, the probe of the pulse oximeter, to the finger of another patient. So that sort of things you have to use. Recently, there had been blog post by one of the so-called activists who was admitted at IDH, who was hypoxic, given oxygen. We saw him daily, we spoke to him daily, assessed his situation, and then he improved and he went home. And he has put a blog post saying that the patients are checking their temperatures and patients helping other patients to check the oxygen saturation. So, okay, that's perfectly all right. Unfortunately, that idiot cannot understand that. But that does not mean you should not see the patient. So it is important to observe these patients at least twice a day. If they're having, if they are unstable, you have to observe them more frequently. The observation charts will be discussed in due course by others. So if they're having resting tachycardia, or if they desaturate or become dyspneic on mild exertion, not walking a lot, just by getting out of the bed or going to the toilet, if they can become dyspneic and they can become desaturated. And then when it comes to investigations, we see common problems in these patients, especially hypokalemia, hyperkalemia, and sometimes their platelet counts can be very high, more than 500, 600,000. And therefore, it is important to get these investigations quickly, especially if you make it urgent. If you make an urgent investigation, make sure that you get the report and see the report within next 2 hours. And all other investigations should be seen within the day. If investigation had been sent, don't come to the ward round and say, this was sent, we haven't got the results. That is, if you haven't got the results, that is your problem. If the blood sample corrects, send another one urgently. If it's a problem. If it is an urgent thing, make sure that you see that within 2 hours. Otherwise, no point of sending a sample as an urgent sample. I'm telling this because I have seen patients, and also to add to that, we see, especially in Colombo, various parts of Colombo, we have dengue also these days. So some of these patients can be dengue patients, not COVID, and some of these patients can have both COVID and dengue. And I have seen several patients who were not observed because their blood counts are not checked. When they come, the patient come at 4 o'clock in the afternoon, their blood was sent, not monitored because nobody thought that the patient would go into shock. Next morning, patient was found to be in shock and they have died. This has happened in big hospitals, even in Colombo, because nobody took care, nobody bothered to get the results of the sample, which was sent as an urgent sample to have a look. So it is important to check these things. And then before discharging a patient, we know some of the deaths have been reported after discharge. So you have to assess the patient properly before discharge. Just see whether they can talk without getting dyspnea. Ask them to walk for about 10-15 steps and see whether they become dyspneic. Check the saturation after walking. Check whether they have tachycardia at rest or with mild exertion, or whether they become hypoxic after mild exertion. If that is so, that means there is a problem. So tell your consultant that there's a problem like that. Whether it is okay to send this patient. Otherwise, in a rush ward round with a lot of patients, if the saturation is okay, improving, patient is off oxygen, your consultant might say that patient can go home. But make sure that you have checked before the round that whether the patient is becoming hypoxic with mild exertion, whether the patient is becoming tachycardic with mild exertion, and if so, tell your consultant that there's a problem like that. So once again, it is very important to detect problems early, because then we can intervene early and save lives. If a patient is hypoxic, it is important to detect it early and treat it early so that you can save the patient. If there's a delay of 10-15 hours or even 6 hours, that can affect the salvage of the patient. And then, in addition to that, it is important to understand that this is a teamwork. Of course, the healthcare is a teamwork, but when it comes to dengue, it is a teamwork. Especially, you have to understand that always one can see something which you don't see. Sometimes even the minor staff people come and might tell you that this patient is out of breath. So you have to give due attention to those things. And those people have been working in wards for years. Some minor staff people, there are very good people who are quite observant in the staff. Some nurses who have worked for years, and they know when they see these patients, they know these things. So listen to them. If they tell something, that does not mean you have to always accept what they say, but listen to them and respect their opinion. And then if you have a problem, always obtain the opinion of a senior person. Just don't write in the ticket that for senior opinion and keep quiet. If there's a problem, contact a senior person and ask what to do. Writing it in the ticket only is not going to serve any purpose. And also, when we prescribe something in the ward round, make sure that it happens. If a drug is prescribed, make sure that it is written in the drug chart and it is given. So you have to you are a member of a team, and it is a teamwork, and you have to work with the team to get the best benefit of your work, which is treating the patient, saving the lives of these patients. Thank you. There are some questions in the chat box we will need. Without a pulse oximetry, how to identify hypoxia in a COVID patient? You can suspect if the respiratory rate goes up, or if the patient is complaining of getting dyspneic with slightest exertion. So that is what we do in home care. If they cannot, if they don't have a pulse oximeter at home, we ask them whether they become short of breath after walking for about 10-12 steps, or from bed to the toilet if the toilet is close by, or getting out of the bed if they are complaining of feeling out of breath. Then you have to suspect possible hypoxia. But in the ward, you have to have a pulse oximeter. There is no excuse for not having a pulse oximeter, because it's not an expensive item. That portable one I showed is probably about 100,000, and there are enough donors also for this sort of things. So at homes, people are there without pulse oximeters, of course. So we have to go with what they say. But in the ward, you have to have that. In the home-based care, how do we differentiate actual shortness of breath with just general body weakness? It can be difficult, but we have to give the benefit of doubt to the patient. If you think it is possibly hypoxia, best thing is to admit that patient rather than taking a chance. If there's no way of checking the pulse oximetry. Sometimes they're finding it difficult to get up from the bed, going to the toilet, because, as you said, because of the general weakness. But so it may be hypoxia also. If it is something like that, best thing is to admit these patients. I'm just randomly getting this selected this question. Can there be complications even after 14 days? Yes, there can be complications. But if the patient was completely all right for the first 14 days, it is extremely unlikely for that patient to get a complication after 14 days. If the patient was hypoxic during the first 14 days, at some point in the first 14 days, then they can have problems after that. So that is why some of these patients need follow-up, and that is why you need to make sure that the patient is okay by the time you discharge the patient. And then in addition to this, we see a very unfortunate thing done by our own doctors. Some of these patients who are either at home care or who come with various symptoms to general practitioners or even to private hospitals, or even when they are at these intermediate centers run by private hospitals, these patients are given dexamethasone unnecessarily. Dexamethasone is indicated for a patient who is hypoxic only, not for other patients. If the patient is given dexamethasone early, now dexamethasone all these drugs have side effects, especially steroids. Unnecessary use of steroids can cause complications and even death. Now, it is a generally accepted thing that the one reason for the high incidence of deaths occurred in India was due to abuse of steroids. People were giving a lot of steroids in general practice. Now, we have come to that stage too. It's unfortunately, some of our doctors have started using steroids unnecessarily. And so there are symptoms might not manifest fully. Patients might feel better, and patient might go home with that from intermediate center, and then they get either secondary infections or their hypoxia get worse, and then they get admitted with full-blown pneumonia after going home. So that is a very unfortunate situation. Do not do that. Dexamethasone should not be given to patients who are not hypoxic. The patient, how long a patient can spread the infection, generally for about 10 days from the time of the onset of symptoms. But if the patient is having severe symptoms like severe pneumonia, then the patient can put the virus out for a longer period, maybe even 2 to 3 weeks. That's why we say in severe cases to keep the patient isolated for 3 weeks. Otherwise, if the patient is not having severe symptoms, then you don't. Then the infectious period is about 10 days.
So there is another one question, how to suspect dengue in a COVID patient clinically?
Yeah, clinically it may be difficult actually. So if the patient is having, so that is why in an admitted patient it's important to do a blood count and check the blood count, especially if the disease has gone on for about 4 or 5 days. It's important to do an urgent blood count and to check the blood count, because if the patient is having dengue also, or if it is a dengue patient with COVID or dengue alone, that's the time that you will see changes, and that's the time you can see complications in dengue. So in this period of the time, it is important to do a blood count in these patients and check it. Clinically, it can be difficult to differentiate because the symptoms can be similar, especially the body aches and so on. If the patient has less respiratory symptoms, think more of dengue. But if the patient is having respiratory symptoms, then we cannot exclude dengue. We have to think of that too.
Then there is another one, please explain about long COVID.
COVID patients can have other various symptoms after they become non-infectious, or they are discharged from the hospital, or they are discharged from their quarantine period. It's not uncommon to have lethargy, general body weakness, which can go on for a couple of days or maybe even a couple of weeks. Those are not very significant things. But then, especially people who had pneumonia or significant pneumonia can have other effects like the lung fibrosis, which we have to look at and think of and treat appropriately. And there are occasions of other things, but those are other things are uncommon. Other things are rare.
There are so many questions. I will select few. One thing, what about can they have orthopnea or dyspnea during sleep without exertional dyspnea?
That is very uncommon. If the exertional dyspnea is the main thing, because what happens is when you exert, the body needs more blood, more oxygen. So that's the simple thing, or simple rationale. However, in an obese patients, the hypoxia can become prominent when they sleep, because they have the sleep apnea component also. So even their normal life, they can be little hypoxic during their sleep, and that can become more prominent in a COVID patients who is very obese. So we notice people who are, when they are awake, they will be seated, their saturation is good, but when they are asleep, their saturation can go up to 80s. And generally, so in the night, we give some oxygen to such patients, but generally it's not a big problem.
How to identify happy hypoxia before discharging a patient?
As I said, it is you can exert the patient mildly. Ask the patient to walk about 10 steps or 10, 12 steps, or you can ask the patient to sit and stand for about 8 to 10 times on a chair, and then check the saturation. If that is, if it is going down, then you know that is the patient is becoming hypoxic. So better to keep such patients if they are getting hypoxic or if they get significant tachycardia. Now, some of these patients, even with mild exertion, the heart rate can go up to 125, 30, that sort of range. Going it up to 100, 110 is common, even with slight exertion. We see that common in these patients. But if it goes up to high levels, then you have to think, then you should not discharge such patients. And of course, then probably we have to think of other possibilities, either their pulmonary, the pneumonia has not got better yet, or the fibrosis, pulmonary fibrosis is setting in, or they are getting small pulmonary emboli. So those things should be considered if they become hypoxic even on, say, day 14 or day 20 with mild exertion.
Then advantage of giving antibiotics to all COVID patients, is there any advantage?
No, actually, it's disadvantageous. It should not be done. Don't give antibiotic to all COVID patients, which is useless. COVID is a viral infection. There's no prophylactic antibiotic recommended. So don't give antibiotic to COVID patients. So if during the first 6 to 7 days, it is extremely unlikely that these patients will need antibiotics. So don't prescribe antibiotics. It is very unfortunate to see using azithromycin in these patients. Azithromycin is a very useful drug which should be reserved for specific infections. It is very unfortunate that doctors just blindly giving antibiotics. I mean, doctors are people who know this, who should know this. But they blindly give this, especially erythromycin, in the general practice also, and also in these quarantine centers run by hotels, run by private hospitals. We see this this bad practice, and then when they get secondary infections, they are resistant. So don't use antibiotics. And even when they become hypoxic, if they become hypoxic, sometimes even now with this Delta variant, we see patients becoming hypoxic as early as day 4 or 5, and such patients do not need antibiotics. Now, for some reason, this sort of so-called triple therapy had been prescribed in hypoxic patients. Hypoxic patients we give dexamethasone and enoxaparin for hypoxic patients, but all the hypoxic patients do not need antibiotics. So it's not triple, actually it has to be dual therapy for hypoxic patients. If they have any evidence of a bacterial infection, if there's a suspicion, yes, then you give antibiotic, but not otherwise, not especially in the early part of the illness.
Then what about the prophylactic anticoagulants in home care?
At the moment, it is not recommended because it's not, there had been several studies and it had not shown any benefit. So that is why it is not recommended still. And also, there had been cases of not only thrombosis, there had been cases of bleeding also. So that is why one has to be careful when giving this sort of these drugs.
Then options available as antipyretic when fever is responding to paracetamol.
Now that is a common problem in dengue. More than in COVID. But don't give any other antipyretic if it is not responding to paracetamol. Just you can do tepid sponging, putting a fan, that sort of thing. The fever is not going to kill the patient. But in dengue patient, NSAIDs can kill the patient. So don't use NSAIDs.
Only one question, otherwise it will come so many questions. Final one, zinc and vitamin D. What is the role of zinc and vitamin D in COVID patients and other vitamin all together?
It might have a placebo effect. Otherwise, there is no use. So if the patient is in the ward, if the patient is not getting anything, then giving a placebo is okay. I agree with that, because then the patient will be seen by somebody at least once a day. Otherwise, for COVID, there's no place for vitamin D or vitamin C as a treatment or prophylaxis.
Okay, thank you, sir. Other questions, mostly other things are related to investigation. So you can ask them tomorrow with Dr. Malika Karnaratna, consultant microbiologist. So we will end, otherwise we will have no time for other lectures. So thank you very much for spending your valuable time with these pre-intern doctors. Thank you very much. Prashant, can we have?
Yes, sir. Next up is investigating and treating COVID positive patient. Is by Dr. Situmini Bahalagamage, consultant physician at IDH. Madam, over to you.
Good morning, everybody. Today I'm going to speak to you all about what to expect and what to do when you go as brand new interns. You get this now. Most of the hospitals are filled with COVID patients. So we are just going to touch upon the investigations and treatments that and what you should be aware about as interns in looking after these patients. So I'm sure you are aware about this course of illness and what to expect. You know, these are from the data is from previous old statistics, and it says 80% have mild illness, 15% have severe illness, and 5% won't have critical illness. 2.5% will unfortunately die due to COVID. With the new virulent strains, these statistics may have changed a bit. Sorry. So when you go to the ward and now you are the doctor looking after these patients, it's very important that when you see patients, when a patient comes to you, it's very important that you maintain this daily status and you do a good job at monitoring and looking at the parameters of monitoring. It's very important to get a good history and do the examination of patients once at least, of all patients, all the patients who come in through the door. The ones having mild illness, moderate illness, severe illness, anybody who comes through the door of your ward, just do a proper history and examination first. And this is, of course, mandatory in complicated and unwell patients. Because sometimes there could be reservations because these are COVID patients, these are infective, and we have seen instances and we have heard many media reports saying that the doctors are not looking after patients, not seeing the patients, not examining the patients, and it's very important. You can't sort of answer to all the things people say, but it's very important to pick out the proper cases and do the examination and history taking in a proper way. So I would like to touch upon briefly on the pathophysiology of this COVID-19. You all know that there is a pulmonary phase and there is a pro-inflammatory phase where there is a cytokine storm happening, and also there is this condition is a prothrombotic condition, and so basically these three are important in targeting the therapy. And so COVID-19 affects all the organs in your body. You name it, it will affect all. So you will be, if you ask a patient what the problem they are experiencing is, you will see, they will say all these things, and they will have fever, headache, conjunctivitis, they will have cardiovascular complaints, they will have GI related complaints, they will have severe muscle pains, joint pains, and some will have skin rashes, skin complaints, and you name it, it will be there. So what we do in this daily status and monitoring, it's important that you at least will need to monitor these patients twice daily, because not like in previous days, we can't rush to the ward, we can't do like rush to the ward anytime, we need to put on PPEs and everything, so we sort of are monitoring these patients through these parameters, through machines sometimes. And it's very important to monitor these patients' blood pressure, heart rate, respiratory rate, oxygen level, at least twice a day. And also, most of these patients coming to you, most of the current hospital admissions are patients who have other comorbidities like diabetes, hypertension. So, in addition to this basic blood pressure, heart rate, respiratory rate, you need to monitor CBS in a diabetic who's having poor control. And in kidney injury, sepsis, dengue with COVID, in those cases, it's important to monitor urine output and be alert about reduced urine output. And there are cancer patients coming with who has had chemotherapy. They may be neutropenic, so you may need to monitor their blood counts. So according to the individual patient need, you will have to test this monitoring. And also, if a patient is if you mark a patient as potential to become severe or in a severe patient, the frequency of monitoring should should be increased. And so investigations, the blood investigations, and when to do. Should we do investigations? Should we investigate all patients with COVID? In a fit, young, healthy patient with no symptoms, maybe we don't need investigations. They're just there. If most of these patients are now being managed at home, but anyway, if you come across such a patient, they may not need much investigations. And but if you get elderly patients with comorbidities, it will be very important to if a patient comes with past history of heart disease, some arrhythmias, it will be good to have a baseline, ECG of them. It will be good to have a baseline like chest X-ray in a patient with chronic lung disease, even before them becoming critical. And so anybody with acute symptoms, they need to be investigated. Even a young, fit, healthy adult coming with high fever, you need to investigate them. You need to look for any other coexisting abnormalities, like some patients have COVID plus dengue. So it's very important to have a blood count in a patient running high fevers, because basically you cannot differentiate these two things. They share symptoms, so you need to investigate. And so basic investigations in full blood count. We have seen lymphopenia, leukocytosis, leukopenia, thrombocytopenia. Some of them have thrombocytosis, and we have seen quite a number of patients having elevated hemoglobin. So any of these things you can expect in a full blood count. And you need to do inflammatory markers, and you will see them usually elevated. CRP, ESR, ferritin, those things will be elevated. It doesn't, a high CRP in a COVID-19 patient, say even 100 of CRP in a COVID-19 patient, does not necessarily indicate that the patient is having a coexisting bacterial infection. It could all be related to COVID only. And so you need to do renal function tests in these patients. They can have AKI. And liver function tests. Elevated liver enzymes are very common. Low albumin as a reverse inflammatory marker. And it's so these imaging studies, chest X-ray, ECG, and microbiological investigations. So there is a set of specialized investigations in COVID-19. If you have facilities, you can see them. D-dimer troponin, LDH, and clotting studies. These you can do if you think they are necessary. So if you suspect a patient to be having, say, pulmonary embolism or DVT, you can do a D-dimer and see. But anyway, even if the patient doesn't have a embolus, in severe COVID-19, you will see an increase in D-dimers, troponin, LDH, all these things, because they are really sort of non-specific. But if a D-dimer is negative, that has a good negative predictive value, and you can say that the patient doesn't have any, PE or DVT. But the positive predictive value is pretty low. They can go up in COVID-19. So procalcitonin. Procalcitonin is very important because this is sort of specific for bacterial sepsis and tissue damage. This is if you have facilities to do this, if a patient maybe can afford it, it's a useful predictor in detecting coexisting bacterial infection. This comes handy when you select patients to consider patients to be for giving for tocilizumab. And also, in some patients have ongoing fever spikes, not responding to antibiotics. In such scenarios, procalcitonin comes in handy. So, like I said, D-dimer, CRP, LDH, troponin, ferritin, CPK, they are sort of indicators of severe disease. You will see D-dimers more than 1000, CRP more than 100, very high LDH, and even troponin more than twice the upper limit of normal. These are all indicators of severe disease. So you need to be, if you see this, you need to be on the alert in those patients. And also lymphopenia. Lymphopenia has also been identified as an indicator of severe disease. And I think you will have a in detail lecture about radiology later. These investigations like chest X-ray, ultrasound scan, chest, and CT pulmonary angiogram, HRCT chest, these investigations are important in managing patients, but of course your seniors will direct you initially in which patients you need to do these investigations. And microbiology. Investigations, the cultures, your blood cultures, urine cultures, sputum cultures, and stool cultures in patients having diarrhea, those are very important. If you, like Dr. Vijay Vikrama said earlier, not all the patients with COVID-19 need antibiotics, but if you really suspect a secondary bacterial infection, if you choose to start this patient on antibiotics, always try to do cultures before antibiotics, because that will be very helpful in guiding the antibiotic treatment. And so that is it for the investigations. And what about management? In managing COVID patients in hospital, it's very important that you have an idea about this disease classification. Which patients fall under the mild category, which patients fall under the moderate category, and which patients fall under the severe category. So who are the mild patients? Mild patients are, they could be having, fevers, they could be complaining of cough, they could be complaining of, many other complaints, severe body aches, things like that. But they could still be mild infection if their oxygen saturation is more than 94% on air, and given that they don't have any evidence of deterioration. So that is the mild category. Moderately severe category is anybody who has oxygen saturation less than 94% on room air, but they should not have evidence of dyspnea, like increased respiratory effort, use of accessory muscles of respiration, are evidence of severe disease. Severe disease, that is severe or critical disease, means saturation less than 90% with the maximum oxygen supplements that we can give, or saturation less than 94% on room air with evidence of clinical deterioration, such as respiratory rate more than 30, chest X-rays having more than 50% multilobar infiltration, PF ratio is These are, of course, things that you can obtain from blood gases. And hemodynamics instability, those patients fall under the severe category. So, what can we do? So the general approach, it's very important that these patients are, we need to ensure that they have a good nutrition. I think previously also you already discussed this, vitamin D, vitamin C, zinc supplementation. These of course have very unclear evidence in COVID-19, but they have been identified as agents that can ensure that the patient has a good immunity. And some studies have identified some adverse outcomes with patients with vitamin D deficiency. So the only rationale behind giving these supplementations is to ensure that they have a good nutrition level and good immunity level. Also, hydration is very important. Even for all patients, it's very important when you do your rounds, when you have a look at these patients, always do an assessment about their hydration level. Keep in mind about the comorbidities, like are they heart failure patients, are they patients with renal failure, or are they young, fit, healthy adults who look a bit dehydrated. So each and every patient of these should have a hydration target, and you need to advise them to keep themselves hydrated. If oral hydration is not adequate, try to give some IV. Just make sure that they are adequately hydrated, and advise adequate rest, do the monitoring. And the mild category, the mild disease patients can benefit from breathing exercises, and for some patients, some selected patients, you can get the help of chest physiotherapists. And since COVID-19 is this severe disease, most of the patients you will see that they are anxious, and they will be having complaints that cannot be explained with what you see in their objective parameters. So sometimes reassurance helps, and always try to reassure the patients who look anxious. So this is photo taken at IDH, a few patients doing breathing exercises. Of course, do this in mild category patients, advise this in mild category patients only. And what about if they are hypoxic? What if they are in the moderate or severe disease category? You have to start oxygen therapy. And the acute target of your oxygen, so that if you detect a patient to be having a low oxygen saturation, like 92%, give them oxygen until their saturation is more than 94%. And you should maintain their target oxygen at the rate of 92 to 96%. So what if they have chronic lung disease, like a patient with COPD who usually has low baseline of oxygen saturation? In that case, maintain have low targets, like for COPD it could be 88 to 92%. And also it's very important that we advise patients about awake proning in COVID-19. It's because it has been identified that if you maintain the patients in the supine position, some areas of the lung may not get, especially the posterior areas of the lung may not get ventilated properly. So there will be VQ mismatch, ventilation perfusion mismatch happening. So to prevent this, we usually advise patients to change their position. This is called awake proning. So this is just a photograph of awake proning. What we ask the patients to do is change their positions every 2 hours. Like Be on the left lateral position for 2 hours, and then sit up at a degree of about 60 degrees in the bed for about 2 hours, and then right lateral position, and then prone position. So these positions should be maintained for from 30 minutes to 2 hours. That will ensure there is minimal VQ mismatch happening. But before doing this, especially before putting a patient to prone position, you need to ensure that their oxygen device is securely attached and the patient is not really in distress. And otherwise, the patients can go into arrest in the prone position and it will be difficult to manage them later. And so, oxygen. You're familiar, I hope you're familiar with the conventional oxygen therapy devices like the nasal cannula, your usual face mask, your non-rebreathing mask, your Venturi devices, those things. It's sort of important to get the hang of it, which patients need which, when to start oxygen and which device to start oxygen, and you can guide the nurses when you have this, when you're familiar with it. And so after the conventional oxygen therapy, then some patients need to be escalated to other more sophisticated things like high flow nasal oxygen. High flow nasal oxygen is a device which you can use to give heated humidified oxygen at high rates, high flow rates. And there is a non-invasive ventilation, CPAP or BiPAP. And then if failing those, we may have to think about invasive ventilation strategies. So again, what to offer? Antibiotics only if sufficient evidence to suggest coexisting bacterial infection. Antibiotic choice should be according to individual situation. If you are in doubt, consult microbiologist. And like said earlier, please don't give antibiotics to each and every patient. Not all hypoxic patients need antibiotics, only if you suspect bacterial infection. I just need to mention that if you give antibiotics to all the patients, when it is not actually necessary, the patient will develop resistance, antibiotic resistance. And when these patients are with us for like several weeks, the need for antibiotics will arise. The ICU patients will need antibiotics. When the patients are in hospital, they will need antibiotics with hospital-acquired infections. But when you give antibiotics early in the course of illness, they will develop resistance, and when they actually need antibiotics, there will be no antibiotics that is sensitive to the particular infection. So it's very important that you need to be very rational about antibiotic treatment in COVID-19. And steroids. Steroids is also another thing, like Anand said, give steroids only to patients who need steroids. So, and at the correct dose and the correct duration of treatment. So, who needs steroids? Steroids are only needed in hypoxic patients. So, give the steroid of choice is dexamethasone, 6 milligrams oral or IV. The duration is 10 days or until hospital discharge. If the patient sort of improves quickly, then you can think about stopping the steroid therapy before 10 days, because steroids do have side effects and horrible side effects and that. If dexamethasone is not available for you, equivalent dose of other steroid can be used, like prednisolone 40, methylprednisolone 32 or hydrocortisone 50 milligrams 8 hourly are the equivalent doses of dexamethasone 6. And what about pregnant patients? Always consult an obstetrician and gynecologist opinion for treating these patients. And what about anticoagulation? So like I said earlier, COVID-19 is a prothrombotic condition. They can develop clots everywhere. They can develop DVT, they can have pulmonary emboli, they can have emboli that we don't see in scans. So anticoagulation is important. So it's very important in severe disease patients that we give prophylactic anticoagulation. So all who falls into moderate and severe categories should have prophylactic anticoagulation. So what we have available commonly in our hospitals is enoxaparin. The dose they recommend is 40 milligrams per day if there are no contraindications. And if there is a renal impairment, you are supposed to adjust the dose. So always in CKD patients, when you prescribe anticoagulation, try to calculate the eGFR and adjust the dose accordingly. So who should need therapeutic anticoagulation? Therapeutic anticoagulation is given if the patient is under clinical suspicion of venous thromboembolism, or those patients who have evidence of venous thromboembolism. And what about aspirin? Do you think aspirin has a place? There are no evidence for this, but some of these patients, we have seen that they have very high platelet counts or very high hemoglobins, and this sort of doesn't get corrected with proper hydration. And you know that this can sort of increase their risk of thrombosis. And if they have coexisting comorbidities as well, you can consider giving aspirin, but not for all the patients. So there are specialized treatment options. I'm sure your seniors will be involved in deciding which patients need these specialized treatment options. Tocilizumab, that is an interleukin-6 inhibitor, which if given at correct time, when the patients are having the cytokine storm, this will be beneficial. This can be beneficial. And this should be given when the oxygen requirement goes up and you are pretty sure that the patient doesn't have a bacterial sepsis, because when you give this bacterial sepsis, if there is coexistent bacterial sepsis, the patient can die of sepsis. And there is talk about remdesivir. And there are some trials showing that there is some benefit that it shortens hospitals, but I don't think we have remdesivir available. We may in future, because treatment options keep changing. What about HCQ? Ivermectin. Still, there is no sort of trial evidence for any of these treatment options, and there are several in the pipeline, but the evidence is unclear on these things. And as interns, you will be spending most of your time with these patients, and it's always very important to get a treatment plan for each and every case. So there will be some of these patients who needs ventilation, and some will not be for ventilation. Some patients should be allowed to pass away comfortably. Like if a 90-year-old grandfather comes to you with severe COVID pneumonia, obviously if that patient has been bedridden for several years, that patient will not be for any treatment escalation, will not be for any ICU, it will not be for anything. He should be allowed to pass away comfortably. So you need to discuss with your seniors, get a plan about your severely ill patients in the ward, and keep in mind who needs early escalation, who needs to be, which patients need to be told to your seniors early. So try to get a treatment plan for each and every patient from your seniors. And so most of these patients will be having comorbidities. And initially there were questions about which antihypertensives to be given, Those things because of the pathophysiology, the AC, the virus gets attached to angiotensin converting enzyme receptors. So there was a controversy earlier, but now all antihypertensives are deemed safe. So when you give dexamethasone, it's very important that you keep in mind that this can cause hyperglycemia. So all the patients who are hypoxic, who's receiving dexamethasone, make sure that you monitor their blood sugar levels at least once daily. Most of the hypoglycemias, dexamethasone-induced hypoglycemia starts in the, if you give the drug in the morning, you will see hypoglycemia in the afternoon or evening. So try to monitor their blood sugar levels, and if you detect their sugars are not under control, have a treatment plan, give some insulin. That is a temporary thing. Dexamethasone-induced hypoglycemia will go away when the steroids are stopped. So try to manage it with insulin, and then you can stop it later. Always just keep in mind that this is your usual medical patient. Even if they have COVID-19, they are just your usual patient. They have several other comorbid conditions. It's very important that we don't ignore their comorbid conditions. We do not ignore to monitor the comorbid conditions and give their usual treatment. Even if they are COVID-19, they can get say CNS infection. They can get renal failures. They can get MIs, COVID related or not. Just make sure that all the other medical conditions are properly managed. So this is a new normal condition. Try to learn. It was not like the situation when we had when we did internships, but this is a new normal. Maybe this new normal will be there for several years to come. So learn as much as possible from this new normal. Try to learn as much as possible. And so thank you. And I wish you all the best for the career you are going to start very soon. And I'll be happy to answer any questions if you have. Any questions?
Yeah, there are two questions. So, what is the cutoff for such SpO2 to home-based care?
So it should be 96%. So if a patient who's having home-based care has persistent saturation levels below 96, you should be alert and try to get this patient admitted.
Sorry. Next question is, what are the precautions that the asthmatic patient should get not to get into a critical phase if infected with COVID?
This again must be about home-based care, right?
The preventive measure, preventive daily to take recommended, not.
So I have actually it's pretty odd, but I haven't seen patients coming with acute. A lot of patients who are having asthma, I haven't seen them coming with acute severe asthma with COVID-19. So maybe, but they, of course, they are a high risk category of patients, and to prevent, I guess you will need to use their inhalers properly and avoid the exacerbating factors. Asthmatic patients have, some patients get exacerbations with dust exposure, some patients get exacerbation with cold exposure, so those things you can avoid, and they can use their inhalers properly. Make sure the patient's inhaler technique is proper. And if you see that the patient is having an acute exacerbation of asthma, of course, you can start treatments with steroids. And if a patient is in hospital, we start nebulizations, we start steroids, even if the patient is not hypoxic. Even if we think that this patient is having an acute severe asthma, then we start steroid treatment.
Next question in brief. How to check the patient is in hypoxia, the COVID patient with hypoxia?
Is this about like home-based care? Like Anand said?
Probably, yes. We are asking the same question over and over again. Yeah.
It's sometimes some patients do have intractable cough. When the patients have intractable cough, always suspect hypoxia. And when the patients walk around, you can observe that their respiratory rate goes up, even if they don't tell you that they are feeling short of breath. You can observe that their respiratory rate has gone up, and things like that. So the early identification would be hypoxia when on exertion. If they have a home SpO2 monitor, you can advise them to walk like 10-20 walk for about 3 minutes and then check their saturation. So those things can be done. There is a question that if
there are about 20, they're asking briefly what is post-COVID syndrome. That's one question. Then asking about budesonide inhaler and Montelukast usage.
Right. So budesonide inhaler, I guess yes, there was an observation that for COPD patients, so when COVID started, we thought COPD patients will be a horror to manage, because COPD patients may get severe disease, but we sort of didn't see very much of these chronic COPD patients coming with exacerbations, because in a usual medical ward there are recurrent admissions with COPD patients, but with COVID we didn't see much, and this has been seen, and I think there has been a trial done with budesonide inhalers, which showed some benefit. So they thought the chronic steroid inhaler that the patients were on was sort of protective. That is the basis for giving this budesonide inhaler, but it's not sort of in the recommendations yet. But if for some patients, you can, if they have significant symptoms, you can prescribe, of course, patients with SOB, cough, those initial symptoms not hypoxia or anything, those patients we have seen that they improve with acetylene inhalers, things like that. So that can be, you can give those things rather than giving oral agents like theophylline, which can increase their heart rate, have adverse cardiovascular outcomes and things. You can try with some inhalers for symptomatic benefit. And
there are lots of questions. I think briefly, one question is when the patient can bathe. That's one question after.
Patient is on the recovery. It's a cultural thing. I think in Sri Lanka, most patients are very reluctant to bathe when they have respiratory complications. But when they are on the recovery, or if they don't have significant respiratory symptoms, I don't see any problem in having in showering, you know. You can ask them to shower during daytime.
Yeah.
And,
I think that's.
yeah.
So I think that is a good question. Madam, if the SOPO2 is less than 96%, few minutes, and then it improved to 96,
It's
significant.
Yes. This happens usually when the patient, you know, even if in a patient in a ward, if they walk for some time and if you check saturation with exertion, their saturation goes down. And then sometimes it picks up very quickly. This happens with exertion. If this happens, if you have identified this with exertion, that is important because that patient is at risk of developing hypoxia at rest. But sometimes, if the patient is at rest on the bed, then always when you put the saturation probe in, give some time because the probe will take some time to give you a proper reading. So you have to give some time and wait for that curve to appear. And if the curve is there and once it stabilizes after about a minute, then you get the reading. And if it is persistently normal, then it's okay. Doesn't matter if you initially when you put the probe to the finger, if it reads 89, then it doesn't matter. So always before you decide on the saturation level, see whether that curve is there. That is like that. So if the patient has exerted before, then that could be significant. Did I answer your question?
This is after 14 days, the C2 value is less than 30. Should the quarantine continue, and for how long? When to repeat PCR done?
You need to read this updated discharge criteria. I think for COVID-19 patients. Currently, we don't repeat PCRs. Once the diagnosis is made, we don't repeat PCRs on discharge for these patients. And the guideline is very clear. You don't need to, at the end of 14 days, you don't need to do a repeat PCR. And you don't have to worry about the CT values unless the patient is somebody who has been identified as having significant immunosuppression. So your PCR will still be positive after 14 days. It will be positive for like several months even. Initially, when we didn't know anything about this COVID-19, we kept patients in ward for like several months, up to 3 months even. Until this becomes negative. But it has been found that the virus is not culturable usually after a duration of 10 days. So that is why now there is the recommendation is from the symptom onset, when 10 days have passed and the patient's symptoms have improved, the patient is okay, then we discharge the patients without any PCR testing, serology testing or anything, because their viral load will be low, their organisms will not be culturable, and the risk of transmission will be low. If you suspect that this patient could be still infective, then of course ask them to wear mask, maintain distance from the family members and everything. But we don't usually routinely recommend quarantine after discharge as well. Now it is different.
Right. I think we'll wrap up for today's session of this lecture, because we have to go to another lecture, but most of the question will be answered in following lecturers series as well. So thank you, Dr. Situmani Palakamudi, consultant physician at the IDH. Thank you once again. So next up is an approach to management of COVID patient by Dr. AGS Asin, consultant physician at IDH. I think you're there, yes.
Okay, okay. Now okay, now okay. Hello, can you hear?
Yes, we can hear, sir. Yeah. We can start.
Good morning. Can you hear me?
Yes, we can hear you.
I'm Dr. Asiri, consultant physician from National Institute of Infectious Disease. Yeah, I think you will be starting you are the pre-interns and you will be starting your internship maybe in a couple of months' time. So my topic basically it's an approach to it's a COVID patient management. That is basically the acute the patient, the COVID patient, those who are presenting to us with COVID symptoms. So as you have learned the medical school, this COVID approach to these patients also like your usual medical patients. That is, you have to take a thorough history and then come into a maybe you may think about a diagnosis, and thereafter you may come into a think about a examination if needed, and the investigation and relevant come into a diagnosis and do whatever the management. So the history wise, I would like to emphasize some parts. Firstly, the onset of symptoms, because and the duration from PCR, because like if I tell like cough for 5 days like that, and may have done a PCR the previous day, that is 1 day duration, or the rapid antigen test, that is also maybe different time duration. That is because if it is an asymptomatic patient, we basically go by the PCR or rapid antigen. On the other hand, if it is a symptomatic patient, we go by symptoms if it is relevant to the COVID, and also the discharge and their symptomatology, that is like an onset of pneumonias. Those things occur from there's a timing course like around somewhere 7 days, 5 to 7 or 10 days. During that time, they will develop most of the time pneumonia. So that part is important. And detailed presenting complaint, as you know, whatever the symptom, the coming with cough, it doesn't mean that patient is having COVID. So whether it is related to respiratory tract or it's a cardiovascular heart failure or any other infection like asthma or COPD, to arrive at such a diagnosis, we need to take the proper presenting complaint line and the possible DDs. We have to think about it. So we need to ask a couple of questions. And in addition, these patients generally transferred from other hospitals. So we don't know whether they have taken adequate orally or they are dehydrated. One thing is their appetite has gone down. So they may not be taking properly during a couple of days previously. So therefore we have to think about their well-being, and the appetite also important. The other thing is generally these patients being transferred from faraway places. Their parents will be.
I think sorry to interrupt, sir. I think your slideshow is not moving.
No, I am still in the first. Yeah.
Okay, first one.
First
Yeah.
one. Here I'm in the. Can you? Yeah, first slide.
You mean upload your name and that logo?
No, an approach to patient management.
Okay.
Can you an approach to COVID patient management? Yeah. Is it moving now?
No.
No. This problem, just not moving. Yeah, just we'll try to.
Yeah. Dr. Ahmed, you might close it and share it here.
Okay, is it now?
No.
Moving?
Yeah.
Is it moving?
No.
Close this
Close
time.
it.
Yeah, close it.
Okay?
Yes. Now it's moving. Yeah.
Yeah, and the first slide, yeah, it's like general well-being and the appetite. That is also well-being, because sometimes patients, like a husband will be in one place, the wife will be in another place. Sometimes we have to ask them where they are, and we may have to get them down if we have enough space. So, and they are anxious also. So that is also very important to think about them, because of anxiety itself, there are some of their symptoms like will be seen as exaggerated symptoms you will see due to that. And as you are taking the usual history, the past medical history, that is like having a previous respiratory condition like COPD or asthma. Sometimes in the chronic respiratory condition, their baseline saturation may be somewhere around 88, maybe around 90. So if such a patient come with the same level of saturation, we may initially think, oh, could it be due to COVID, but sometimes it may be just their normal values. And even in like a cyanotic heart diseases, it can occur. And the previous cardiac condition, like a having heart failure, or having the acute past history of myocardial infarction, that also matters because we sometimes have to compare their current ECGs with old changes. And having cancer or being on immunosuppression, that matters especially. One thing for the we consider about their outcome, like the prognosis, it matters. If they're having immunocompromised state, sometimes they may go into severe disease. On the other hand, when we try to discharge the patient, according to the current criteria, there are different, like we may have to consider that part, like considering the duration as well. Not only that, the previous comorbidities and drug history. That is because these patients, when they come into the ward, we'll take the history and we have to give your usual medication, maybe for diabetes, maybe for hypertension, or for ischemic heart disease. This patient, because of having COVID, we are seeing the patient, but you will know that there is some doctor-patient gap. So if you miss things, the patient will not get the proper treatment in that case. And as usual, take the surgical history. And allergies, that is important because we will be prescribing drugs, and sometimes we will go ahead with contrast CTs, etc. And especially in the reproductive age, female, we need to have a menstrual history because we may be doing this radiological imaging, chest x-rays, and we are prescribing some drugs for them. So that is very important. So social history is also plays a lot because they are patient concerns, because sometimes they are one member might have already passed away. They think about it, and they are one member, as I mentioned earlier, in a different institute, and they are far away, and they may be having some other social issues because the patient may be the breadwinner of the family. So these things we need to, at least we need to know. Then we know that there are some of their symptoms are due to they are the psychological or stressful situation that will arise. There are some of worsening of some of the symptoms they develop like without ECG changes or X-ray changes, without that if they develop dyspnea or something, we can think about that part as well. Not only that, drug addiction. Some are heroin addicts. Some people may be taking alcohol, and they are when they come, this is a prolonged state. So by day 5, day 6, they will become aggressive. So it may be alcohol withdrawal. So if we know, if we think about it beforehand, we can manage it before it arises. So there are actually pre-morbid condition, like mobility is one part. So knowing that, that we know this is a bed-bound patient. So even after recovery from COVID, the patient, we will not expect the patient to walk like normal. Because the usual medical patient, their relatives are coming, everyone is visiting, so we know their condition. But these patients usually being transferred or admitted to the ward without anyone proper contact. So knowing that situation will give us a proper clear picture about the pre-morbid condition. Not only that, sometimes when, as we have now, facilities are, there's a, now we have to allocate, like if patient needs ICU or some care, sometimes there is we have to consider their pre-morbid condition because we have a limited resource setting. When the COVID peaks and COVID number of patients goes up. So history part wise, I think that you all know these things from the medical school. And the examination, yes, because we are having usually this blood pressure, pulse rate, respiratory rate, saturation. On admission, they chart their temperature, and according to the severity of the illness, that will be charted usually twice a day, depending on the oxygen and requirement. It will go up the observation. This vital recording. Not only that, the observation is a very important part in these COVID patients. So when you have to observe whether there are accessory muscle usage, if there are the tachypnea, the respiratory rate, and the breathing patterns, any relevant observations is very important. And whenever needed, we have to do this other examination as well. We can't say you can just omit that part. We have to do whenever needed in a relevant patient. So this is a video taken from YouTube, just thoracic abdominal breathing or thoracic abdominal dysynchrony. This is not the first part I want to. This is a first. More than that, I would like to concentrate on the second part of this video. You will see. Sorry. That's not. Just observe the second part of the video. Yeah, this is a little bit like a thoracic abdominal dysynchrony or the seesaw type of breathing. Then when the patient is feeling sad, you will see. This is taken from YouTube. So just to observe this. So, and this is the observation chart. Earlier we practiced when the patient is not on oxygen. Then when they are on oxygen, this sort of a chart, like you see like very frequent monitoring and what is the oxygen saturation level and what is the FiO2, the oxygen percentage we are giving. That is how many liters per minute. And which type CPAP or high flow oxygen, that sort of a thing, because now current day most of the patients are on oxygen. So that's two different charts actually. This is like a when they are like a mild disease like that, but this is when they are having severe or moderate disease when they are requiring oxygen. Then I will just like to just one case scenario. Couple of case scenarios I will be discussing. This is a previously healthy 45-year-old male present to the hospital with COVID positive PCR report, and which they have done 4 days prior, and then he has symptoms for 8 days. So, and complaints of shortness of breath on exertion, occasional chest pain while breathing, and dry cough the following day of admission. So it's like a day 8-9. So respiratory rate 18 without accessory muscle involvement, and blood pressure normal with saturation is around 93 on room air with temperature of 100. The other investigations are pending. So what are the things? So it's a PCR report positive patient coming on day somewhere around 8 of illness coming with SOB with chest pain. So anyway, you will think it could be COVID pneumonia. That I think other possibilities. You may think it may be like ischemic, like acute coronary syndrome could it be. There are a couple of other diagnoses also, but for the I mean, just for the discussion, I just think about those two things. And what the maybe pneumonia and the acute coronary syndrome. Then you will do maybe basic investigation initially. This is the chest X-ray, which shows some peripheral complications, so more I mean favoring pneumonia, and you will be having the same the radiology lecture I think following this lecture, and the next and the ECG taken normal. So this is S1Q3 pattern, just to exclude pulmonary embolism. I just mentioned that also can be a differential diagnosis, and chest X-ray is suggestive of pneumonia. So we are now thinking about COVID pneumonia. So our patient is having 93% on room. Yeah, so their severity wise, I think we have a very good guideline. So this is moderate severity. This is I'm just recapitulating on the theory part. Saturation is equal or less than 94 on room air without evidence of increased inspiratory effort. So there we think about moderate condition, and severe category where saturation will be less than 90 on maximum oxygen supplement, or saturation less than 94 on oxygen and evidence of deterioration, whatever the with the accessory muscle involvement or abdominal dysynchrony and some progressive changes in the chest X-ray, or hemodynamic instability due to COVID, and PF ratio, that is a partial pressure of oxygen, like in our atmosphere, it's like P partial pressure we can get from the ABG, and this is I think the HDU setting things. Just I theory part, I'm thinking that there will be two fraction of inspired oxygen. It's like 21%, like 0.21 in that case. So that is that, and so that comes like whether it's like acute lung injury or ARDS, that sort of a categorization, which I think you may not need at this moment. And SF ratio is saturation to fraction of inspired oxygen ratio. Just these are theoretical part, but in the board setting we will be mostly go by saturation and this respiratory rate, chest X-ray involvement, and those things, and accessory muscle involvement. So our patient actually having moderate because he's having saturation of 93 with without any involvement of accessory muscle. So probably we'll be monitoring this heart rate, respiration, saturation 4 hourly, and it depends on progression and investigation. Yes, basically we will do maybe full blood count, CRP, SGLT, and renal, that's creatinine, electrolytes, those things. And the management, then I'll come this, because this is a moderate degree, we can manage probably at a low flow devices. That is low flow, I mean oxygen devices. Low flow means that their oxygen is like a less than 15 liters per minute, like that can be usually given in a ward setting, in a normal ward setting. And that device is usually divided into like a fixed flow devices and variable devices. These are variable. That why I am telling is that when you give if you think about a face mask or venturi mask, face mask, it's a variable oxygen. I come into that matter later, I think next thing, yes. So you can deliver up to 15 liters per minute from non-rebreathing mask. The target saturation would be 92 to 96, but in COPD it will be less. But if less than 5 liters per minute, I think we can give from a bedside oxygen concentrators. Even there are some oxygen concentrators which can deliver even up to 10 liters per minute currently. So regarding these oxygen devices, this is nasal cannula. So that is a variable. So we don't know which oxygen percentage we are delivering actually. So generally we can deliver 1 to 4 liters, where we can deliver about 24 to 36% approximately that level of oxygen. It may be varied a little bit. Then after that we can deliver through a face mask, simple one. 5 to 10 liters you will be giving oxygen. So from that it will deliver about 40 to 60% of oxygen to the patient. Then after 60, yes, we need to have another device. That is a collector, reservoir bag. That is an unrebreathed face mask, the bag and mask, where you can deliver up to 60, maybe 85, 90, or a little bit beyond that percentage of oxygen, where you need to give at least 10 to 15 liters per minute oxygen, where that will be collected in this bag and it will fill, and the patient takes breath from that bag. So it will deliver maybe up to 90, sometimes 90, 95, yeah, maximum oxygen. So that is the low flow. Then actually the devices would be high flow devices. Above this level, if we are to deliver, it will be high flow. But I think in my lecture, I'm not going to discuss its high flow nasal oxygen. We can deliver through one with high flow therapy. Other thing is the CPAP device, and next one is the mechanical ventilation. So these are the things I think you will come across initially in the ward, but high flow and the CPAP device also have to be used now because of current setting. Then venturi mask. These can deliver a fixed oxygen percentage. That's why they are the fixed performance device, they call it. Where just like a green one, if you give 15 liters, it will deliver about 60%, and the red one, like 10 liters, it will deliver about 40% of oxygen. So these devices also we can use in ward settings, especially COVID, not before COVID, like COPD patients, we use these devices to deliver proper concentration of, that is like percentage of oxygen. Venturi we fix it to a mask. Then what about, apart from that simple thing, phoning, that will actually improve oxygenation. So that is like I have mentioned, like there are a lot of videos you can read about it. Like if you phone the patient about 2:30 to half an hour, there are maybe supine position, little bit prop up, then one side lateral, then the prone position, then likewise can improve the oxygenation. Secondly, the dexamethasone is around 6 milligram per day for 10 days. And anticoagulation, so generally it's 40 milligram per day, or and sometimes it can be adjusted according to the renal function. Antibiotic not needed always, like initial phase, usually in COVID infection, it's due to COVID itself. But later, maybe after day 5, 6 later, they can have even hospital acquired or other infection. If you suspect, if you think about it, antibiotic, you need to take a blood culture before that. And even CRP go up in COVID pneumonia itself. Then what we think about is a daily status. So we'll observe their respiratory pattern, whether they are getting tachypnea, whether they have, there's a deterioration of the liver. And their hydration also important because of oxygenation and those things. They will have a lot of, they will get dehydrated without our knowledge. And the urine output may be a very important part in that case. Because whatever we do to improve our saturation, unless it goes to the, it is pumped through the heart to the tissues, there's no point if there's no proper cardiac output. So we need to have a proper circulation to deliver that oxygen to the tissues. So their appetite already having a poor appetite, so hydration and their blood sugar control also sometimes get erratic, like it will go up due to COVID itself. So we need to manage those things, and there are some other investigation like D-dimers, procalcitonin to detect an infection, and serum ferritin. Those things when they develop, the patient develop pneumonia, and thereafter we have to see whether how the patient is improving or whether the patient is deteriorating. So that is the first case scenario. The second one, second case scenario is a bit different one. Just to think about these things now, because you will be having this exposure when you go to a COVID or whatever the medical ward. So this is a 50-year-old previously healthy male diagnosed with COVID-19, developed fever on day 8 of illness. The vital signs, X-ray, they are normal. And later, 2 days later, informed that he is ill and blood pressure found to be low. So what are the things we have to consider? Here, I think we can think about shock and like low blood pressure. So it may be like COVID patient, so maybe poor appetite, maybe dehydration, so it may be hypovolemia. Could it be like due to like day 8 of the illness? So can it be like due to infection, sepsis or something settling in? And can it be what cardiogenic? Because cardiogenic, that's a possibility. So we may think those things, especially when the blood pressure goes down. That's volume depletion, so it can be hypolimic or cardiogenic. So basically we can do ECG, we can assess any volume status, and we can do other investigation to come into any infection to rule it out. So ECG normal, inflammatory markers are high. So, but it can happen in COVID, but in this context, clinically we initially think, should it be septic shock, and we have to, if the patient is properly hydrated, that is very important. So just these are some definitions and some guidelines. So any sepsis is any life-threatening organ dysfunction caused by dysregulation of host response. That is either suspected or proven infection. So they can have like low oxygen saturation, reduced urine output, tachycardia, and blood pressure will be low, and mottling and coagulopathy, thrombocytopenia. There was evidence of tissue hypoxia that can happen. Then the septic shock. So the other mean arterial blood pressure is more than 95. To maintain that, they require vasopressors. So that is mean arterial blood pressure is diastolic blood pressure plus the 1/3 of the pulse pressure. That in this patient, I think it is 80/50. So 50 is the diastolic blood pressure, 80 is the systole, so pulse pressure is 80 minus 50, that is 30. 1/3 of that is 10. So 50 plus 10 is somewhere around 60. So below. So actually you don't need to, in the ward setting, you don't need to calculate, but when the blood pressure goes by, maybe depending on the patient's body weight, low blood pressure, maybe less than 90 by 60. It's not a real cutoff, but you can think about when you see the patient's condition, you will come in, the patient is going into shock. So we have to recognize it, and so we have to that is be sure that is, as the definition mentioned, persistent hypotension despite volume resuscitation. So the volume is adequate, but still their blood pressure has gone down. So this is a definition, but when it comes into clinical practice, we may be giving a bolus, maybe 250 to 500 crystalloid bolus we can use in maybe 20 minutes to 30 minutes time, and see how the blood pressure response is. Then you may repeat it. Then you may consider, if the volume status is all right, then consider about vasopressor. So especially noradrenaline is the first line treatment in this septic shock. So you will start antibiotic after taking blood cultures, and then monitor vitals to detect improvement or deterioration. This is the basics. So that is when the patient, this is a case scenario, actually COVID patient, but patient has gone into septic shock. So that also we need to think. COVID means that all other medical conditions come in these COVID patients. Another case scenario, that is a 30-year-old male with diagnosed COVID-19, PCR positive for 2 days, that is PCR positive 2 days back, and presented with fever for 5 days. So, and vitals normal, including saturation, but he felt a little bit dizzy while getting up from the bed, and his gait and basic neurological examination, they were normal. He found to have 100,000 of platelets with normal HP. So what could be? If we considering about this low marginal platelet. So these 4. So could it be something like dengue? Yes. What case? Like maybe lepto? Yeah. Maybe even sepsis possible. So those are the main things think about. There are other possibilities as well. So actually this patient CRP, creatinine, LFTs, they were normal, and we started dengue monitoring when because of this platelet count when it's dropping, and ultrasound scan as usual. That is for other patients, not even non-dengue patient like that, we had to monitor with ultrasound scan, and the patient actually went into dengue hemorrhagic fever. So, and then we manage that part as in the usual way, and patient recovered. So always in all the other medical conditions happens in COVID-19 patients. I think this is the last case scenario. That is a 50-year-old diagnosed COVID-19 patient who developed chest pain and sweating on 4th day after admission. She is a diabetic and became breathless, tachypneic, and oxygen saturation dropped to 93 on room air. Blood pressure was 100 by 60. So this is a chest pain with sweating. So could it be ischemia? That is acute coronary syndrome. That is one possibility we need to think. And what are the other possibilities? And becoming tachypneic, saturation also dropping. Could it be that's COVID patient, maybe COVID pneumonia? We have to think. Even there are some other diagnoses we may have to think. Maybe there are pulmonary with rare possibility, maybe acute coronary syndrome with heart failure, severe COVID pneumonia, and pulmonary embolism, but it's rare. So we have to do the necessary basic, maybe at least ECG, and do a chest X-ray, come into a initial diagnosis, and done. And there were ST elevations in V1 to V4, and chest X-ray reveal pulmonary edema. So this is, we can actually easily miss. We may think this is COVID pneumonia, but it's not pneumonia. Actually, patient is going into acute coronary syndrome and developing pulmonary edema, which can actually, through the mild and proper management and other anticoagulation, we can actually recover the patient. Sometimes the saturation also improve very quickly, as it is not COVID. I think not everything like acute stroke happen, and pulmonary embolism, even UTI, meningitis, cellulitis, and surgical or obstetric emergency, everything can happen in a COVID. So we need to have we need to think always all the possibilities depending on their symptoms and the signs and whatever the relevant information. So just to regarding the glycemic control, where these COVID patients, they have a tendency to have a insulin resistance is one thing, and these patients not taking adequate oral and they don't take medication. So because of that, and the patient on steroids, so their glycemic control tends to be poor. So we have to keep somewhere around, not a very strict control, somewhere around this range, and we can give maybe intermediate acting insulin or insulins to control that, to get the proper control during the hospital stay, especially when they are on steroids. And just keep an eye on acute kidney injury, not very common, but because of dehydration and COVID related things, their creatinine can go up, and we, with proper hydration and proper investigation, we have to keep an eye, because we may be giving some drugs, and so we'll have to monitor these parts. So I think these are the things I wanted to mention about this. I talk about this acute COVID patients, how to approach, what we have to think in those patients. So I think that is the end of my lecture about things. Any questions or anything I can clarify? Yes.
One question, sir, repeatedly asking, can you explain the post-COVID syndrome?
No, there are, that is, I mean, they mentioned like after 4 weeks time, that's a post-COVID period. Then after 3 months, there's another disease, acute COVID, and like a long COVID syndrome after 3 months, like that, as I can remember. They can have different symptoms, like even from myalgia or SOB. Those are related to, like those have been named as post-COVID manifestations. This is a lot of, that's like as a syndrome, that is a lot of collection of lot of symptoms. So that part, I mean, it's actually full separately discussing topic. So I think if you are to tell, like even insomnolence, like that, all the symptoms, almost all the symptoms can occur, and it has been divided, as I can remember, after 4 weeks. There's a acute COVID, post-COVID, and then long COVID syndrome after persistence of symptoms after 4 months, 3 months. So apart from that, I think those symptoms occur and happens, and there are different management. So I think that is what at this moment I'm able to tell. Yeah, that I think there are lectures and lectures on this topic. It's a separate entity actually. It happens and it's there. It is divided as I mentioned. Is that okay?
There's another question, sir. They're asking, is it recommended to combine the combination of antibiotic, atypical coverage, with COVID patient pneumonia before blood culture results are available?
Yeah, the thing is like antibiotic generally within first 5 days, fever is usually due to COVID itself. Even if you do CRP, it will be high. If you can do procalcitonin, if it is high, you can consider, because procalcitonin is a marker of infection, you can start, but generally you can take a blood culture and wait for maybe 2-3 days. If you are really worried this is the patient becomes maybe sepsis or it's due to bacterial infection, then you take a blood culture and add antibiotic with the atypical coverage. Yes, but it's not not the first thing you need to do, and it is better if you can get microbiology opinion if you have a microbiologist. But generally, the first 4-5 days fever is due to that COVID itself, and maybe due to pneumonia itself. But when it goes beyond day 10 to like that time, like near 2 weeks thereafter, it's usually due to secondary infections or bacterial or sometimes fungal.
Right. Another question, sir. Please say the doses of vitamin C and zinc.
Zinc, I think that, to my knowledge, is it a proven? I don't think vitamin C. The vitamin D, zinc, there's some recommend if they're having a deficiency to give. Apart from that, proven benefit, I am not sure about that. Those two things. So because of that, I will not tell about any dose. There are people prescribing those things. Yes.
Another question is concerns about selection of oral anti-diabetic drugs during acute COVID management.
Yeah, the thing is, if the patient it's a diabetic patient, if the patient is if the patient is on oral anti-diabetic, you can continue if it is getting control. That's one thing. You can continue unless patient is going into like the acidotic state like that. You can continue for the oral drugs. In addition, when we start Dexa or steroid, the blood sugar tends to get worse. Then you can add like a maybe lente insulin twice a day dose to control that part. That's the easy way. Or else, that is the easiest way. Else, you can convert to soluble insulin and maybe long-acting insulin, but it's a little bit difficult because now it's not like you don't frequently go in and out from the ward. So we need to have like a twice a day regime, like then maximally thrice a day regime. Otherwise, it's a little bit difficult. So if the patient is on oral, we can continue. If it is getting deteriorated, we may be able to add maybe intermediate or long-acting insulin. That would be the easiest way.
I think most of the questions are regarding this testing and discharging. I think you can find them in health ministry website and epidemiology website. One more question for the last. Can you please mention the HBC dearrangement in COVID-19 patients?
Sorry?
full blood count dearrangement in COVID-19 patients.
Yeah, COVID patient, like if you are to, I mean, I'm just thinking why you have asked that, like in the full blood count, we can't just by seeing a full blood count, you cannot diagnose COVID. They are having, sometimes they will have thrombocytopenias, but maybe low, because it's a viral infection. And WBC count also sometimes get low. Apart from that, in some patients, their PCV tend to go up, and hemoglobin, especially sometimes it will go like a polycythemia, maybe 17, 18, that like because maybe due to hypoxia, or even without hypoxia, it will go like that. Those are the things. Apart from that, by seeing a COVID full blood count, there's no way to come into a diagnosis, I think. So it's generally, it's like a viral infection like count we will see usually.
Okay, sir. The last question is, sir, does the mean fever due to COVID virus usually resolve within nearly first 10 days?
Yeah, it's like it's chronologically, like if the patient develops infection, so in first maybe 5-6 days, that is like a initial phase, you will have fever spikes, upper respiratory symptoms, and it will settle maybe by 4th-5th day. Then there is a like a fever-free period. Then if fever recurs around 8, 9, 10 days, then we generally think that maybe due to pneumonia. If the patient if they develop pneumonia, they will again have fever spikes generally. This is a general thing, this is not common to everyone, but generally initial fever spikes, body aches, then it will settle after 4-5 days. Then 8-10 days, like around day 7-8, they may develop fever spike with dry cough. Yes, then we may have to think about whether the patient is developing pneumonia, and with that we have to think about desaturation and those things. That is the general pattern. Then if it goes beyond, now if the patient develops pneumonia, then pneumonia also generally tend to settle by day 20, sometime around that time. If it goes even after that, we have to think about organizing pneumonia. There are sequence of events, organizing pneumonias, fibrosis, and those things. So in between, like a pneumonia and the organizing pneumonia, in between what happens is like a day 14, 15, these infections, like secondary infections occurs. That is the chronological order. And the fever generally settles, if it's a mild disease, like day 5, by day 5-6, fever settles, and it will be okay even after that, day 7, 8, 9, 10. Is that?
Yeah, so I think that's all. Thank you very much. That is Dr. A.G.S. Asiri, consultant physician at IDX. Thank you, sir, once again. So we might skip today's tea break, and we go to the next lecture. Imaging inputs to diagnose COVID-19 patient and its complications by Dr. Kishani Abewardana,